My name is Jim Gochis from Synergy Dental Partners. I'm just setting up the slideshow here for you to view. And welcome to our webinar tonight. It's a great topic. It's AI, which is very timely. From insight to action, harnessing dental AI for trust and team alignment. And we have some great presenters here from partners of Synergy. Synergy is a GPO in the dental space, the largest and longest running, where we help dentists maximize their savings and price availability at aggressive rates nationwide, and Overjet and Dental Education Partners are partnered with us. And AI is so timely now. I think no one can deny that in every aspect of our lives, we're being touched by it, whether it's a Google search or a conversation or something that we're seeing in imagery. Sometimes we even question, is it AI or not? It's very prevalent and making great inroads in the clinical space, in the healthcare sector. And for dentistry, we're seeing a lot of opportunity there that is now coming to fruition. It was always a concept and a discussion for many years, and now it's actually happening in a dental practice. And that is where patients are getting an enhanced level of quality of care. Clinicians are enabled with a deeper view into making clinical diagnoses. It's also related to enhanced case acceptance for a patient, and which results in ultimately in revenue growth for a dental practice. So there are a lot of things that are happening, and our experts today are Dr. Parag Kachalia, who is the head of clinical practice over at Overjet, and he's a fellow of the American Dental Education Association's Leadership Institute, a researcher, as well as a published author in the areas of dental technology, digital diagnostics, contemporary fixed prosthodontics, and financial management. He has lectured internationally in the areas of adhesive dentistry, cosmetic dentistry, photography, CAD/CAM technology, fixed prosthodontics, treatment planning, erosion, and diagnostic technologies. Dr. Kachalia acts as a consultant for many materials, dental technology companies, and helps guide product development. He also is a member of the Pride Technology Leadership Council and is frequently interviewed in regards to his vision of dentistry's future. And also with us is Mary Hughes, who is the owner of Dental Education Partners. And Mary is the leader and founder of the company, a highly regarded agency that offers the most current topics in dentistry today for teams across North America. Beyond clinical practice, Mary's certified by Achieve Global as a professional selling skills trainer, showcasing her experience and expertise coaching dental teams to improve patient understanding and increasing treatment acceptance. An esteemed member of the American Dental Hygienists Association and a published contributor to dental journals, Mary's an internationally recognized speaker, known for her engaging and charismatic teaching style, which you will see today. And with that, we will turn it over to Mary and Dr. Kachalia in just a moment. What I would like to share with you here is just a statement here on how we are connected. So this is a disclosure that we want to share with you, where, as I mentioned, Dr. Kachalia is an employee with Overjet. Mary is with Dental Education Partners. I am with Synergy Dental Partners. I am the Chief Procurement Officer, and commercial support for this CE program is provided by the three companies together. And now I'll turn it over to Mary and Dr. Kachalia at the end. Stay tuned. Make sure you listen in for how you can claim your CE credit. And I'll tell you a little bit more about how Synergy is partnered with these companies and how we can benefit dentists nationwide. Thank you.
Thanks so much, Jim. I think it's amazing, when you look at what some of the clinical objectives really are for why we incorporate AI into our practices and why we use it. It helps us first to, number one, really get aligned as far as a clinical team in the practice, for us to be able to really truly see how it actually helps us both clinically and also operationally when it comes to the workflows that we do, and creating efficiencies in those areas as well too. And it builds trust between us as providers and also when we're presenting to patients. And I think, by using something like Overjet AI, specifically in our practice, when I'm with my patients in hygiene, we started to talk about when we were going to implement it, what the difficulty was between all of us in the office as hygienists. Some of us work part-time, some of us work full-time, and it was difficult to really align that way. And so really kind of understanding when you're looking at the CDC that states that over 60% of the general practice have undiagnosed or untreated periodontal disease. And really, when we're looking at, or for periodontal disease in general, and over 80%, they say across the United States, the American Academy of Periodontology shares that 80% of us in general dental practices don't properly diagnose or treatment periodontal disease in its earliest stages. And really, when you look at their overall statistics, they've stated that almost 50% of our adult population in our office over the age of 30 present with some level of periodontal disease, whether that's gingivitis or early stage periodontal disease that we have to manage for the life of the patient. And when you kind of look at that number and then realize that each year, not us as providers, of course, but our patients are getting older every single year. And so as we start to see our population of patients age, when we look at over 65 years of age, that prevalence of periodontal disease jumps from 47% up to about 70% of our patients who are 65 and older, which really presents us with a challenge of how do we change the way that we've always been treating our patients? And sometimes even when we start to look at them coming in and updating their medical histories, we then find that a lot of our patients, specifically our patients 30 to 65, will then be in an age group where they start to be diagnosed with different types of medical issues or systemic diseases that they're having. And we all know in dentistry, of course, that there is a comorbidity that exists between periodontal disease and chronic inflammation and other systemic diseases that our patients are being diagnosed with, from diabetes to cardiovascular disease to Alzheimer's, which has been the latest in a lot of our journals this year, is really kind of understanding that chronic persistent inflammation in our patients, specifically in the hygiene patients that are scheduled perhaps for a prophy, are coming in, and we're not really sure what the process should be of how to move them from a healthy or preventative therapy to a more therapeutic in-depth procedure. And how do we do that by explaining that? Well, with the AAP telling us about these statistics in periodontal disease in our general dental practices of being 80%, that we're not recognizing and or treating it appropriately, they then came out with the AAP staging and grading in 2018, which, working with offices even as recently as this afternoon, a lot of us in hygiene struggle with identifying the severity or the stage of periodontal disease. And so a lot of offices will say, well, our basic protocol is we start to treat at 5 millimeters or greater and things like that. And when you look at the AAP staging and grading, that stage of a 5 millimeter pocket is at a stage 2. And so then it causes us to pause and sort of reflect, what are we doing with precursors to perio, meaning gingivitis? And then how do we move to start to treat the earliest stage of stage 1 disease? And that really kind of creates some confusion. And even working with teams, the hygienist will, give their best guess at what the stage of the periodontal disease is, of the severity and the extent of it. And dentists, a lot of times, want to put that into our camp for us to make that hygiene diagnosis. So we understand that we have to establish the severity of the disease and then go one step further to create the grade or the rate of progression, which helps us to identify how the patients will respond to treatment, what impact that periodontal stage will have on their overall systemic health. And being able to do this effectively, working with teams, they say, well, how are we grading? And this section here that shows a percent of bone loss, and there's a .25 number, and what does that mean? And all of those things. And as you recall from school, in order for us to get the bone loss percentage, we were taught a methodology. So we learned that we had to measure the radiographic bone loss, measure from the CEJ to the apex on the radiograph, then subtract 2 millimeters from the CEJ to where the bone level should be to get where the bone level is today. And then we do some division and then some multiplication, and there's just a whole lot of math. And so it's a very complex procedure to actually stage and grade our periodontal patients or our hygiene patients, which we're supposed to list and document in our patient notes. But it's such a complex way for us to be able to do this that oftentimes the hygienist looks to the dentist for clarity or to create the periodontal diagnosis of staging and grading. And the dentist will then share that they're actually looking for me as the hygienist to be able to stage and grade the patient, and when they come in for the hygiene exam, to deliver that information to them. And so I'm thinking the doctor's going to do it. The doctor assumes that I'm going to do it. And what ends up happening is that none of us are really confident at how we're supposed to periodontally stage and grade because it is a complex process. And so Dr. Prague and I were talking about this even yesterday. If it's that complex between the two providers, between the doctor and the hygienist, how can we then present any treatment recommendations to the patient with any level of confidence that what we're doing is the right thing, or how to show them where we got from a healthy cleaning, so to speak, to now needing periodontal treatment or therapy that they might require in order for us to arrest that disease right where it is and to try to put it into some sort of remission. And so I think by utilizing things like AI, I think it helps us to build not only our confidence between us as providers, but also how we present to the patients so that they then can have confidence in what our recommendations are, and then to see things as we're seeing them through our lens as well too. Dr. Prague, do you want to add anything to that as far as patients' ability to build trust with us and each other?
I think it's so crucial today from the trust standpoint, the trust equation, and I look forward to sharing, I can share you more. But I think you hit a great point. Our patients are living so much longer today, right? But we have a generation that believed in everything we did, and now that's starting to change. So how are we going to go forward in that aspect to take a complex issue like periodontal disease and get patients to believe in it when many operate in the world of, as long as I don't floss, things don't bleed, right? It's to get past that mentality. No, this is just hidden disease that's in your mouth, and we're trying to work with you to show it to you. So I look
Yeah.
forward to it.
Just
Fantastic.
sharing that. And I also think too, I think even kind of looking at how we integrate it into the workflow of, now we have this amazing software that we can use for our patients. And then how do we integrate that into it? So I love the topic when you present on this too, as far as our trust level with our patients, because I think it's truly impactful and it's eye-opening too.
Thank you. Well, Mary, thank you so much for a beautiful start to the presentation, and it's an honor to be with the group today. As we enter the holiday season, what we start to look at is entering 2025, the world has changed. And quite frankly, since COVID, we live in a very, very different world. And the institutions of trust that people have historically had, like that's all changed drastically. So the next 20 minutes or 25 minutes or so, I hope to share with you kind of where I see the world today with respect to what's changed. We'll look at some big picture concepts. And then where AI can be used appropriately, like an ethical usage of AI, where AI is not here to replace any one of us as clinicians today. Rather, AI is an adjunct, right? It's almost like having an associate or a partner that's side by side with you in care to look at things further and ultimately foster patient trust. So as we go through that, I kind of alluded to this a little bit. My mom just turned 83 years old this year. And if I think about my mother at 83 years of age, she operated in a mindset of where she walked into a doctor's office, the degrees on the wall, the white coats there, the names on the door, and there's trust, right? There's an immediate trust just because they're the learned individual. She trusts her hygienist, she trusts her doctor, she trusts everyone that's part of the medical establishment because she felt like they earned that by having an office. Flash forward, I'm a Gen Xer. I'm that sandwich generation that's operating between now taking care of my mother at 83 and also taking care of my child at 16. So in that in-between world, building trust with me is very different than it may be with her, and it's definitely very different than it is with my son. But if we take our Gen X or our millennials today, Gen Ys, at one point we thought of these individuals as those camping out in front of the Apple store waiting for the newest iPhone release. And the reality today is they're our primary patient base. They're the working population. They're having their own children today. And for them to build trust in our practices is very, very different than anything we've had in the past. So years ago, we'd say, oh, the millennials are the trophy generation, and we're not going to really worry about them. And the reality is, say, they're our workforce, they're our employees in terms of our employees. They're also having benefits that come in, they have their own families. This is the world, this is the future. And when we think about that future, we have to have a reality of they've grown up in a very different world that's been very data driven. They've had access to information their entire life. So it wasn't a blind trust. It wasn't simply, you tell me what's going on, I take it at face value and go forward. Instead, I want to do research with it. And if we start to look at how they integrate with the medical world today, many millennials are putting off significant health components because they feel like they're going to other areas to figure out what's going on, right? They're considered the wellness generation, but at the same time, many put off a health issue for more than a year. 25% haven't had a physical in over 5 years. Now, at some point, life does catch up to you. We know that, but we start to operate in, well, why are they in this role? What's the belief? Why are they in this point where they're not seeking healthcare today? And part of the reason is they have this role where they have lots of data. That data is telling them things to have them believe that they're healthy. And partially true, but what about all the things that are not tested, right? So their Apple Watch is telling them they're not having a heart attack, their heart rate's in good shape. Their Oura Ring is telling them how well they slept and what their oxygen saturation may be. They have apps that work with their Pelotons or tonal mirrors or whatever has happened. And it gives them these constant metrics, right? All these metrics are there telling them what's going on. And if those metrics show they're healthy, they're fine. And on top of that, if they wear their Lululemon or their Viore, they definitely believe they're healthy, right? Because that's like the badge of honor to say you're in good shape. But life is beyond that. And the reality today is many individuals across multiple generations, but especially the millennials, when they think about their satisfaction with their medical doctor today, we're seeing deterioration. There's definitely deterioration happening in that world because partly there's not an inherent relationship that's been built, right? We've all gone to medical establishments today where you get maybe 5 minutes with a clinician before you're off to somebody else. Now that's maybe starting to happen in dentistry a little bit, but they at least see us more often. And we have the opportunity to continue to build this trust equation with them and not necessarily have them go to only a Facebook, an Instagram, a YouTube, etc. We're not going to keep that from happening. So there has to be, we have to embrace it. Chat GPT and other things are part of our life today. People are going to go to those areas to curate information. But how do we build that? We're also a place of information and trust. Now, one of the sad parts is if we look at these 3 bullet points here, is they trust our doctors less than other generations. They believe information online is as reliable as medical professionals. And a significant number trust their peers more than medical professionals. So what that means today is essentially if you're ranked 1 through 5 on a Google page, people think that that's all correct information. These individuals are not going to PubMed. They're not doing a Google Scholar search to find out what's happening in healthcare. They're literally going to Instagram to see what a colleague says, see what a peer says. So our screen time has to become important. If we learn from that Instagram rule today, pictures mean everything. The visual portion is what gets people to react to things. I think back and kind of dating myself now. I'm 49 years of age, and when I was a little kid and we would want to go to a hotel, my dad would get out the AAA guide. If anyone remembers that, I think there'd be this AAA guide he kind of flips through, and there'd be a hotel, and he'd be like, "Okay, we're gonna go to a hotel with this many stars." And we didn't grow up with a lot of means, so we never got to a 5-star hotel, but we splurged on like a 4-star hotel for us, and all you knew was a statement in the book, and you didn't know what the hotel actually looked like until you got there. Now, can we imagine that in today's world? Would you ever go to a hotel not knowing what it's going to look like? Like nobody would do that today, right? We curate every single thing that we do from what we eat to the type of Uber we step foot into. But when we look at dentistry, right, there's this place that there's this distrust occurring in the medical and dental worlds. And part of it is things like this. And as much as a lot of us may despise social media at times, there is something to learn from it and be aware of it. So if you go to Reddit on any given day of the week, you'll run across a Reddit thread that will talk about dentistry and talk about healthcare, right? And if we look a little closer at this Reddit thread, and you have a chance to kind of read what's on your screen, what you'll start to see is, I'll read this loud to everyone, even though obviously you can read it. It goes, "My partner and I do not have health insurance and have not for a long time. We also both both have dental trauma from going to the cheapest possible dentist and getting what we paid for. Due to some visible and concerning damage to a few of my partner's teeth, we finally went to get cleanings and get set up for getting our teeth back in shape. And my partner was told he needed 2 teeth pulled, 2 other cavities, and that he could get that taken care of in a few 4 visits. We have a decent amount in savings account. We can afford this if it's legit and necessary. My issue is I'm not a pro medical estimate reader, and I don't necessarily know what the codes even mean. Internet research, however, has led me to believe that this estimate shows 11 fillings and 1 tooth removal, and I really just want to know if I need to find a new dentist because this smells scammy. Thanks in advance. Right? That's what's posted on Reddit with a "this smells scammy." And we ask why, because I think as a profession, none of us go to work every morning saying, we really want to pull the wool over someone's eyes, right? We all have this intent to do right by our patients, the best thing possible, but the system historically has been set up in a way where there hasn't been a lot of visual proof. And historically, we didn't need that. And what happens for the most part today, not a right or wrong, it's just what happens, but the world has to change, is if I, as a doctor, am walking into my hygiene room for a recall examination, the reality is I might have a few minutes in that room, and I'm counting on my team in a diagnostic approach to be able to empower the patient to make a sound decision. But historically, and I'm just as guilty as many people, is I've told them things, I've said things, I haven't showed them things, and they walk to the front, the front checkout area, and they have nice team members up there, and they present a treatment plan like this patient was presented on Reddit, where it has procedure codes and light items with things that they don't understand, with services that have MD, OL, or B, right, and a dollar amount next to it, and suddenly a $4,000 charge. And we've spoken to this patient for a few minutes in the hygiene operatory. And the question occurs is really where else in your own life, think of yourself just as a human being, do you walk in and someone presents you with a $2,000 to $4,000 treatment plan, never having seen the problem or felt the problem yourself? But in dentistry, we do it all the time. Happens all the time. But if it happens to us in other parts of our life, we get quite frustrated. So what can we do to get beyond this, right? How do we get to the next stage of saying, let's empower our patients with a knowledge base to make a well-informed decision. So oral health care is central to their well-being, right? And part of that is, as clinicians, first and foremost, we need to see clearly. That diagnosis starts with what you can see, right? And what we can see is based on the frame of reference in mind of what we're looking for based on our education and CE courses, et cetera. But the other part of, quite frankly, what we can see is just how clear the diagnostic information data is. And I understand there's a lot of concerns around AI today. People think AI is going to replace them, that AI might not be accurate, et cetera. Like those are valid concerns that people need to have when they test any new technology. But at the same time, we also need to embrace that technology has improved to the point that is allowing the things that we always do to become better. And so I'll give you this example as a piece of information. So here's a standard radiograph that was taken in one of the offices that Overjet works with. Okay, this is directly what came into their imaging software from their sensor. And radiographs like this happen across the country, across the world every day. And obviously we can see the exposure level on this radiograph is not ideal. And so we have the decision to make saying, well, ideally, let's expose another radiograph with the right the correct exposure, maybe correct placement, et cetera, and see what's happening. But if I'm forced to diagnose based on this radiograph, I really can't see what's going on. Right? I have a partial information, and sure enough, yeah, I might see something on the distal of 12, and maybe the distal of of 20 and 21. Those lesions are present. But what if I can see it clearer? What if the AI was trained not to just look for potential areas of disease, but we actually trained our AI at Overjet to actually read enamel and dent and bone and pulpal tissue, and take the data that you've always captured and make your X-ray more crisp? And this is not a standard imaging filter where it's a contrast and gamma change, et cetera. This is understanding true anatomical form and allowing you to be the best of you, just pure imaging. And then on top of that, we actually layer the AI findings, right? So on top of that, now to the patient, we say, Mrs. Jones, And every practice has a Mrs. Jones, 'cause that's what we always say all the time, right? But it's, do you see these gray spots? Do you see these black spots in your teeth? And to a degree, they may say yes, but color is so much more impactful. Because just like the driving down the street, we know green is good and red is bad, and yellow is hopefully yield and evaluate, right? So we know that in this aspect, the red needs to be treated, the yellows may be more incipient. And if we look at the bone levels, the good news for the patient here today is periodontally, they may be more stable. They have nice, healthy bone aspects. We're measuring CEJ to bony crest. But caries-wise, there's some issues. So we have to understand that, but then we also need to put the clinician in control. So one thing, if you're evaluating AI systems to look at is, are you in control of the data that's there? And what I mean by that is if I take a look at this radiograph and I don't agree with the finding, you as a clinician should be able to turn off anything that you don't agree with. So in our platform, the simple eyeball icon allows you to turn things off, allows you to educate your patient and see what's possible. So the patient here sees, yes, there's a giant issue happening in team number 15, but guess what? My hygiene team is also now empowered to have the conversation with the patient saying, look at this bone loss of over 3 millimeters that's occurred on these teeth. And if you don't want to go down the same road as maybe your parents that you checked on your form and said that they lost teeth at a very early age, we may need to be proactive here and start to not only treat the caries that's there, but the periodontal disease as well. By the two kind of go hand in hand, but allows that conversation to be in control. But to build trust in the system, I think for all of us as clinicians, we have to understand, well, how is a system built? Because I cannot empower my team to show AI findings to patients if I can't get them to understand how things are developed in the first place. What we never want to do is to bring a technology into office that's quote unquote a selling tool, right? This is a diagnostic tool that allows a patient to be empowered. It allows a team to be empowered, all my team members, to be able to have the same conversation. That it no longer needs to be doctor-centric. Because quite frankly, there's a generation that trusts me as a doctor. There's another generation that's going to get confirmation from my hygienist. And there's another generation that needs confirmation from the front office team. And everybody needs to be on board together. So the way we train these models is we train the AI to say, we're going to take a specific AI model and make it very, very good at only one thing. So one AI algorithm only reads the CEJ, one only reads enamel, one only reads bone, one only reads dentin, etc. So imagine you had a clinical team that was an expert in each one of these singular aspects. That's how the models are built. And then we tie all those models together and we pair that with clinicians. We take a series of data sets, we show it to clinicians, and the AI is trained by clinicians. And we say, tell me what you see here. And we ask 75 clinicians to go ahead and annotate these radiographs on every single caries issue they see or calculus they see, etc. And this is what we get back. And this is the problem that we've heard in dentistry time and time again. You send one data set out and you get lots of different opinions and choices, because how did I see that grade differently? And quite frankly, I'm a better radiograph reader at 8 o'clock in the morning when I'm fresh than at 5:30 in the afternoon when I'm trying to run out of the office. So we send this data set out, and these are all the markings we get. We look at the highest intensity of blue and find here are the commonalities. These are the areas where we have the highest number of clinicians agree that there's something going on here, and that is a data set we use to train the AI. It is not simple just opinion across the board. And that's why I want everyone to understand this is clinically trained AI. So as we do that, now we can bring the AI a new data set that it's never seen. Say, here's a raw input you've never seen, that it goes through our machine learning algorithms. All those filters get applied to it for tooth, bone, enamel, dentin, etc. All that gets applied to it, and that ends up with an output. So we take the image on the left, where yes, all of us clinicians can notice very large restorations, missing tooth, tip tooths, heavy calculus that's present. We don't need to be able to see that. Like we can see that's obvious disease, and we can see the obvious caries on the mesial 3. But did we all pick up the incipient caries on the mesial 4? Right now that I've shown it to you on the right-hand side, sure, it's like, oh, it's definitely there. But retrospectively, you can always see things. But what about the front end? And this patient further can now understand, yes, that barnacle that's sitting on the side of the root surface has now led to that area bleeding when they're flossing, and has led to the bone loss that's present. And this becomes a moving the patient forward concept where there's trust and education. And getting back to that factor, the time constraints that we have. The reality is, I'm in my recall examinations for somewhere between 3 and 7 minutes. And if I hit over 7 minutes, I can look, my hygienist is fantastic. We've been working together for like 18 years. But there's a little part of us probably pointing at her watch saying, it's time for you to get out of my room. Because if you want me to stay on time and do my job and educate the patient and have the rapport that I need to have with them, you can't be here forever chit-chatting. Like, you need to leave, right? And so that means we need to have a co-diagnostic standpoint because we're pressed for time. And if we don't want dentistry to become a commodity, we have to continue to build relationships with our patients. Because I don't want to give up asking them where they went on vacation, how the kids are doing, right? Those things are important to build connection. Otherwise, we're just a commodity of dentistry. And I need my team empowered to do the exact same thing, because I want them to have that rapport time. But I don't want to give up my clinical knowledge. I don't want to give my clinical ability to this patient. And the reality is, when we're stressed for time, there's 40% less radiographic caries diagnosed and 67% less periodontal. So going back to Mary's point, we live in a world today where our patients are living until they're 85 plus years of age. When I graduated in 2001, it was very common for me to tell a patient, say, Mr. and Mrs. Jones, here's what I think you need. And they were maybe 60-ish years of age. And they'd say to me, Doc, I don't know. I'm too old for this. I don't know if I need to do this because I don't know how much longer I have. Flash forward 23 years, they're still in my practice. They're in their 80s now. They've gone from 60 to 83, 84, 5, whatever it may be. They're not as healthy as they once were. They're doing okay. And there's a little bit of regret today. Like, why didn't we do this sooner? And so I generally tell patients is, you're never going to be healthier than you are today, assuming you're not battling some kind of disease, right? Today's the healthiest you're going to be. Today's the youngest you're going to be. Today's the most able-bodied you're going to be. So let's take care of some of these issues that are at hand before they become bigger problems. So one is that the diagnosis has to happen on our end as a combination dentist hygienist team. We must diagnose together so we catch things. The second part is acceptance. So let me show you a fault of mine. This is from my private practice. I was an Overjet user for 2 years before I became on the team with Overjet itself. And my background's in education. I was a vice chair of restorative dentistry at the University of Pacific, and I was a chief clinical officer at Seattle Study Club. So education, high-level clinical care is kind of close to my heart. But here's a miss. We all miss things. So there is a day, it was last patient of the day. My son, as a competitive golfer, I wanted to go meet with his coach. The meeting was at 6 o'clock. It's about 5:30, and it's going to be tough for me to get out of the office and get to him on time. So I'm getting ready to walk into his recall examination with a patient who's always healthy, like not a whole lot's going on. And so I had my frame of reference as, hey, they're usually healthy. I'm going to go and do my meet and greet and then be on my way. I walk in, took a close look around, didn't see a whole lot going on clinically in the mouth. I pulled up the radiographs, kind of did a cursory look, and I wish I can tell you every bite wing in my office had perfectly open contacts at all times. They don't. I wish they did. But all of us can miss things, right? And I'm just about to walk out the door when I hit the AI, and I noticed the mesial of tooth number 4. Now, if I go back on that image, many of you may have picked it up initially, but now that I show it to you, and I go back, you can kind of see the hint that's there. But it wasn't quite as obvious to me. I saw the distal incipient lesion on 30, did not see the mesial 4. So it's like, okay, well, so what? Is that a big deal? Having confidence that technology of having used it for some time now, I decided to bring that patient, and we decided to open it up. And sure enough, as you kind of clinically go into this tooth, we see that there's caries, well past the DEJ. I use these little protection matrices to make sure we don't hit the adjacent tooth, because 2/3 of all teeth are hit when you do a class 2, right? And as we continue to kind of explore that and take the disease out, where it's a conservative approach, kept things small. I want to bank tooth structure for a long time, so at 85 years of age, they have all their teeth, and we're done. So we look at the use case and we say, great, big deal. Like, we got a class 2 lesion. Is that a big deal? It is from the standpoint of we caught it early. I would have missed it potentially, The patient understands it, can see the colorization of it, and we move forward. But as I've started using the technology, what I didn't realize is cases like this. So this patient walked in as a new patient examination, 21 years of age, not a whole lot going on, minimal restorations, right, in their mouth. We go ahead and part of our diagnostic approach is we take our radiographs, we do an intraoral scan, that's their diagnostic record. And then I went ahead and did the AI findings. I did the AI findings. Sure enough, quite healthy in a lot of different aspects, right? Bone level looks good. But now he's this big red area on tooth number 30. So we go back. You might see a little faint gray around it today. Big area on tooth number 30. Yeah. So what I also want you to notice is while this patient is periodontically stable and you see the green areas of bone, our AI is also smart enough to not measure bone where it cannot see it. So some systems out there today will simply look at the end of the radiograph as the bony level. But how many times we have patients with significant bone loss, we need vertical bite wings, and maybe vertical bite wing isn't taken. And now do we want our AI to falsely say that the end of the radiograph is the bone level? So two things jumped out to me here. One is bone's not measured there because there's no reference point. And two, this red area. And same thing on our side. So if I look at this two clinically, and I'll kind of jump ahead here in that obviously I don't put a rubber dam on the day of new patient examination. So I decided to treat this tooth. And if you look at the occlusal view, there's a composite, little stay in the buccal groove, not a whole lot happening. If we go to the facial standpoint, again, another buccal composite there. Again, I can argue there's a little bit of a marginal discrepancy, but that's being really, really nitpicky. It's a reasonable restoration, asymptomatic patient. But the red was so distinct in the radiograph, and having trusting the technology now, here's what happened. We took that restoration out, and you can see there's massive amounts of decay underneath this area on a 21-year-old. So for all the individuals, whoever used a round burr, every single swipe you take on a 21-year-old, you're now getting closer and closer and closer. There's the occlusal view, and I'll go back to the buccal. And here's what ultimately happened with that patient. We took all the buccal pit composite, occlusal composite out, all the caries out. We're sitting on the pulp, and with the next rotation around, but you're afraid you're going to drop into the pulp. Thankfully, we didn't. It's been about 6 months since we did this now. We restored the case with a simple occlusal buccal two-surface composite, and the patient was asymptomatic. But what we did is we built trust in this patient by using AI and augmenting our knowledge base, right? Doing a restoration that's conservative, not having to condemn this to root canal therapy and a crown, at least not yet, may happen in the future, and build substantial trust with that patient going forward. And they've referred 3 patients since this point, right? But what started with something I never would have seen in the first place. So as we think about this today, what we have to understand is AI is not replacing us. AI is augmenting the best of who we are in a team. It is a new team member is how I think of AI in our offices. That my relationship with my team is expanded now because everybody can have the same conversation in the office. That when I walk into my hygiene operatory, my hygienist has already done a great job of going over the AI findings with the patient to let them know, here's some things that we see today. Dr. Gachaya or Duncan, Dr. Duncan's my wife, are going to come in shortly. They're going to take a look at it again. And they may talk about some of these areas we're seeing. And we get to look at the same data set together. The other beautiful part about this today is, while we all wish there was no insurance things to deal with in the future, the reality is that's not going away anytime soon. It's just the reality of where we are. Is we've worked with 110 million patient lives in the US today. We see how claims are being processed. We know the data set that's being used today. We are now have the ability to have the payers kind of use the same measuring stick as we are, right? And what I mean by that is how often has your hygienist said to you, I really believe this patient needs scaling and root planning. Look at the bone loss levels, look at the calculus, look at the attachment position, look what's happening here, right? You 100% agree. You send that insurance claim off and then it gets denied. Like, wait a minute, I don't understand. We feel like we had all the medical necessity checks that were there in the first place. Why did it get denied? Today, with high confidence, we can say that when we show you a red area on the radiograph, that is the same measuring stick that the payers are using on their end to adjudicate claims. So when we look at AI today, number one is a trust my team has to have in the technology we brought in. As we need to be on the same page that here's something that's valuable for the patient. Yes, I absolutely want the patient to have trust in what we're doing. But my team believes in it, it helps the patient believe in it. Now that my patient believes in it, right, together it allows the industry to move forward. But these little changes need to matter. So what I look for is, one, the AI improves but does not change an image. So it helps us see the best image we could possibly see, does not change it. We have control as a clinician over the findings, and we can distinguish bone level from the end of the X-ray, some of the simple checkpoints for us to look at. And Einstein had a great quote many years ago, obviously, where he said, whoever is careless with the truth in small matters cannot be trusted with important matters. With that, I want to turn it back over to Mary. We'll have a kind of a team approach as we go forward to the next stage. But I just want to give you a sense of where I believe the trust equation stands today with our patients. Thank you.
Yeah, excellent. And I think that, you brought up a lot of really important points that we've talked about in our office as well, too, is at first it was, well, we want to integrate this into our workflow. And so I think, first of all, we had to take the step forward to agree that that's what we were going to do is integrate it into our workflow. So we started with simple, easy steps, right? Which was we implemented it into our morning huddle first. And we were able to then, be able to pick a patient, let's say, when we were integrating it. I selected a patient in the morning, one in the afternoon, that I knew based on what I was finding with them over a period of 11 years that their chronic and persistent bleeding was getting worse and they were losing bone. They had some deeper pocket measurements, but then we started to integrate and use AI. We were able to see exactly what that measurement was. So I would pick two patients of how am I going to convert this patient, right, from their healthy cleaning appointment that they always get, because that's what I always do, to now show them how they can move forward by getting the appropriate therapy that they need to stop the progression of the disease right where it is, right? And then being able to then incorporate the patient right into the clinical care team, which is a very important part of this, which is to create an engagement for the patient where they actually become an active member of the treatment planning team. Not to mention that our business team now finally understood, instead of saying, well, they told you you have DK or they told you you have perio. Instead of that, they could pull up the image too, to your point, and we now have more of a team-led approach, I think, to our office, where the patient knows that we're all in lockstep with what we're looking at, and they're a part of it too because they've seen it as well. And you're absolutely right when it comes to the revenue cycle management and being able to establish that necessity of care. That's really an important part of this as well, because we want to maximize their insurance, of course, and be able to use that as a part of how do we export to insurance to attach to the claim. We found it was significantly higher, first of all, with our co-diagnosing and our diagnosing rates. And also, too, we've also watched our treatment acceptance. And I think that had a lot to do with how we were presenting a lot of this to the patients, to your point, right? Even with the yellow highlighted areas, we changed our whole approach from the hygiene department of, well, we do fluoride on everybody. Your insurance doesn't cover it. It's like $25. Do you want it? No? Okay. Instead of that, we actually could show them, well, these are areas that are not all the way through the enamel to the DEJ yet, but they're headed in that direction. We can do a simple remineralization after I polish your teeth to be able to remineralize those areas and make them stronger and reduce the likelihood that it will turn into some of the larger fillings that Mrs. Jones has in her mouth today, and stop that process from happening and let the patient be a part of, well, yeah, I see it there and I see the yellow there, and yes, we should probably take care of that. And so I think to your point is creating that visibility to the patient instead of looking at the image of, yeah, I think I see where it's darker there, or converting a lot of things that we would put on watch before, having more confidence when we're talking to patients also.
So Mary, I think that's so powerful what you said, especially with making patients part of the process of their diagnosis, right? Is, if you think about just education as a whole, the university systems, high schools, et cetera, have kind of moved beyond the sage on the stage standpoint and had a collaborative learning approach. But in healthcare, lots of time, it's a one-way conversation. We're saying you must do X, and here's what I see. And to your point, like it is a phenomenal journey to be able to sit there with a patient when they start pointing out things, right? Like they're suddenly saying, well, what about this yellow spot? And what about that red spot and that green spot? And be able to have that on and off standpoint to the point now, and you may be doing something similar in your office, is we actually send our patients, we export the findings. We can just take that image that's exported when they don't come in for care and be like, remember this big red spot we talked about the last time, right? So it's no longer like the Snoopy postcard that's being sent out for recall. It's, hey, we don't want this yellow to turn into a red, and we want to kind of get it back to the green if we can, right? In an ideal world. So I think,
And a lot of them will call back when they get it too, right? Or even, you show that treatment plan that was on Reddit. And I think that that is true. And that's how our software is always printed out, the treatment plan, right? So it does look confusing and like it's in another language and those kinds of things. I think you always use that reference point of when you get your oil changed and the guy comes in and he shows you the filter from your engine and it's black and you're breathing this and you're like, how do I even know that came from my car? And all those feelings of mistrust that we all sometimes have as consumers, being able to attach that findings to a treatment plan so that if they do want to go home and talk to their family about the treatment plan, they actually can point and show where we were talking about so that their family can also see those issues as well. And patients have come back and they were like, so we did a whole education on the dental care that I need. I did it with my wife and I showed her these areas. And I feel like I could almost be like a doctor now, which is you want them to feel comfortable with what it is we're saying. And I think incorporating patient communication, we kind of talked about it as a team of how are we going to present this to the patient? We're just going to go, look what we have. Isn't this cool? And what were we going to say? And I think a lot of it had to do with we now have cutting edge technology, which helps us to scan your x-rays and identify any areas that we would need to further investigate with you. And it also helps us, you said we want to hear about your family vacation and the plans that you have. And we sort of lost that a little bit, I think, before all of this, because we lost that time to really make that connection. And you're right, with the millennial generation and things like that, they're looking for that connection, that personal touch. Whereas if we have this co-pilot or this second set of eyes or a second opinion to sort of help us with that diagnosis process, it moves things along much more efficiently. Not to mention, of course, when I used to have to, and I'm dating myself, back in the 1900s, I would have to actually go through and chart audit my charts and visibly go into the patient records to see who needed a perio charting, who needed x-rays, who needed all these things. And now to have something to say, the patient is now due for this, it was like, well, this is awesome. Just to have that part of it saved me probably 15 to 30 minutes a day of not having to do those chart preps and chart audits ahead of time. I can still go in and double check of what the patient needs, but it saved me a tremendous amount of time just in having that, for sure.
Absolutely. I think, kind of getting to your point also in that the chart out piece, as well as that communication between kind of doctor, patient, and hygienist, right? Like, how are we all working together? And there's a great question in the chat that's asking, like, how do we get past this world of not wanting to diagnose, not wanting to have that conversation with the patient? And so diagnosis always has like a loaded kind of term and phrase with it from a legality standpoint, who can and cannot do it. So I think it's educating the patient. So maybe I take the diagnosis terminology off of it a little bit. Can we collectively work together as a team to give the patient the best information possible? And sure, at the end of the day, the doctor may be responsible for ultimate diagnosis. That's fine.
Right, everything falls on you, for sure.
Yeah. But let's work in a team approach. And so I think for me, the question was like, how do we empower our teams to do it? So part of it is my hygienist knows that she's allowed to point out anything she sees. So number one is I have to trust in my team. You have to have the trust in me to say, I trust you. You're with this patient for 45 minutes to an hour, what it may be, and or whatever it may be. It's far longer than 5 minutes. I know that, right? It's far longer than the 5 minutes I'm with the patient. You're going to find things that I'm not able to find. You have the conversation time, the patient's trust that's built into you. Feel free to show them things. And then when my wife come in, we're going to confirm what's there and then help create a treatment plan. But to me, it's an empowerment component, right? I think it's empowering my team, number one, to feel comfortable. But I'd love to get your thoughts on this.
I 100% agree. And I think that, and it speaks volumes to your point as well, especially when the doctor can say, feel free to point things out. And so, working with teams across the country, it's really kind of sitting down and collaboratively saying, go ahead and open these conversations, because if you're seeing this, and certainly when you come in or the doctor comes in to do the exam, I'm going to point out all of those things that I saw and our conversations that we had. So I might say, I talked to Mrs. Jones about X, Y, and Z. Here's what I'm proposing as far as a treatment from the perio side or the hygiene side. And we said we would wait for you to come in and those kinds of things, and have your final confirmation on the findings. What we also found too is if I was expecting the doctor to come in, let's say for a patient who might benefit from having, let's say, an implant, if I was expecting the doctor to come in at that ready and go, hurry up and diagnose every single, looking at the watch kind of a thing, putting that pressure on the doctor, it was much easier for me to be able to just ask my doctor, when would you like me to begin opening the conversation with the patient about an implant? And I would begin to talk about it with the patient. And when the doctor came in, the doctor would say, I would say, is this patient a good candidate? We started to talk about this. We wanted to know what you thought. And in that way, we sound more like a team that's taking care of holistically the patient. And I agree with that, because I think in our office, we sort of say, hygiene is responsible for the foundation of the bone and the tissues. And the doctor is really focused on the function part of the patient's anatomy and their dentition. But together, we're supposed to make this comprehensive approach to how we treat patients. And so I think it kind of brought us together from the both sides of the house, if you will, to bring us together for comprehensive care. And I think that's really where it helps strengthen us as a clinical team.
Totally agree. Couldn't agree more.
And I think it was kind of understanding that not only did it build trust, and I think it did that for the hygienists and the doctors in our practice, but also for the business team with the patient, being able to show a lot of the things that we were talking about and mirroring what we were saying in the back. Because as we all know, the doctor might, diagnose or prescribe a crown for a patient on number 30. And then as soon as the doctor leaves, the patient says, Mary, do I really need that?
Right.
And at that point of time, I'm like, well, the person with 1,800 years of education just walked out. Did you want me to go grab him and bring him back? Or, right? But they asked me. And then I find out that they asked the same thing at the front desk. Do I really need this, or can I wait on it? So it feels like the patient's always looking for that one person that will say, nah, you can wait. But if we're all looking at it the same way, it really helped to streamline our communication processes with our patients, for sure.
Agreed. And the one thing I would add to that, I think that like the daily huddle page
Mhm.
has now really helped us in that aspect as well, to kind of all be on the same page with that, with the findings. So
Yeah.
couldn't agree more with everything you said today.
Yeah, for sure. And I think we covered really a lot of information. And certainly if there are questions, I know in chat and things like that, we would want to encourage you to ask questions, especially if you've been kind of thinking about ideas of AI for 2025 in your practice and those kinds of things. We want to encourage that. So we'll kind of take a look and at the questions and sort of see that they currently use a team approach and gain alignment. And where do you export the image was a question as well, on Overjet. And if you go into the daily patients page, or if you click on where the image is, it'll then say in the upper left-hand corner, either you can exit back or you can export to insurance. And if you export that same image for insurance, it'll ask with or without findings, and which we would always include the findings with our treatment plan.
That's right.
And now I think we are going to, if there's no other questions, certainly we wanted to just say, for us, I think in dentistry, it was really sort of encouraging ourselves to sort of learn for really how to do old things, if you will. Not that any of us are old, but old things in a new way. And I think, a lot of the fears of, how does this work and how does this fit into what I'm doing? It was really kind of, an embracing of technology, of what we're using every day, to your point, Doctor, that we use every day, whether it's Google or Apple Music, of you might like this song and those kinds of things, that we have become accustomed to it. So I would say on behalf of myself and Dr. Prague and your patients, thank you guys for watching tonight. I'm going to turn it over to Jim.
Okay, well, thank you, Mary and Dr. Kachalia. Let me just get to the screen share and show my slides. And I just wanted to add, if possible, here we go. Let me move that. Thank you. As a patient, listening to this fantastic conversation, educational, insightful, very informative. As a patient in my own dentist practice, Mary, you talk about back in the 1900s, I'll tell you back in the 1800s. Gone are the days where the dentist used to, do the film and it was on that white light board on the side where the patient wasn't involved or engaged or saw anything. Now I'm seeing a full screen right in front of me while I'm in the chair. The hygienist, everything you're both saying is happening for me. And I feel very much a part of the process. And case accept, I get it. And it's not like they're having to convince me of anything. They're laying the data out for me and they're having the conversation with me. The hygienist is seeing it, working on me, and making comments about some of the things she or he sees, and then confers with the doctor. They're pointing out information on the screen about whatever might be going on with a crown in my mouth or a replacement that's needed. They employ AI as well in their practice, and it's a beautiful process. Getting all kinds of patient personalities in the chair and being able to speak to those different types of personality profiles is always challenging. But when you have the right solutions and education around that and technology, the groundwork is laid. So just wanted to say that. Thank you so much for this. So just to close out before I turn it over to Tori and she explains to everybody how to claim their CE, mention here that Synergy Dental Partners, as I said at the beginning of the meeting, is GPO, Group Purchasing Organization in the dental industry, the largest and longest running. We are partnered with Mary's company, Dental Education Partners, and Dr. Kachalia's company, Overjet. We have special rates and discounts for our members. I just want to let you know that. We would love to hear from you. So please see the information here. There's a QR code. You can reach to our VP of Sales, super friendly guy. You can look us up on the web at the synergydentalpartners.com and learn more about us. And Tori,